right, so good, mo- good morning, everyone, and thank you for being here early to join us for this session. Welcome to this session, and we are going to, for this session, focus on optimizing universal health coverage for palliative care for adults and children in Caribbean and African countries. And we're going to look at policy and practices in the countries. Um, for much of the discussions we've heard so far during this conference, the focus have been on the Asian, African countries and other parts of the world. We really have not heard much about the Caribbean, so this is an opportunity to hear what is happening in the Caribbean and to look at our plans to advocate or at least some approaches that we can use to advocate for palliative care in the Caribbean so that we can be on par with other countries. I have with me a panel. First of all, I am Dr. Lindonna Telesford, and I am from St. George's University. I am an assistant dean at the university in the School of Medicine, as well as an associate professor in the School of Graduate Studies, specifically in the Department of Public Health and Preventive Medicine. And I am in the global health as well as environmental and occupational health track. I am also the founder of the Caribbean Cancer Portal, and that's a virtual platform that is used to provide preventive education, cancer prevention education, as well as education for cancer patients across the Caribbean countries. And with me this morning, I have a team of experts, I would say, a diverse team. We have Dr. Owen Gabriel to the end. So Dr. Gabriel is a practicing oncologist in the public and private sectors in St. Lucia, as well as the neighboring island of St. Vincent for over 2 decades. So he has been a long-standing practicing oncologist in the region. He was the first ever specialist in the field of oncology for his country and also applied his skills in public health activities. His experience has afforded him opportunities to work as a consultant with the Pan American Health Organization and the IAEA for the development and implementation of national cancer prevention programs for Trinidad and Tobago and Guyana. He has obtained training in palliative care through the Palliative Care Education and Practice Program at Harvard University. Next to him is Dr. Tamara Green, and she is from the beautiful island, Irie, Jamaica, if you will. She is a community palliative care physician and field consultant in psycho-oncology, psychosocial oncology. She's based in Jamaica, and she co-chairs the Caribbean Psycho-Oncology Steering Committee, which serves to create leadership in the discipline through partnerships with communities of healthcare professionals and healthcare recipients advocates in regional and private health sectors. Then we have Dr. Christine Eden, and Dr. Eden represents the French African countries, palliative care for children. She is a retired pediatric oncologist and an advocate and leader of various projects for palliative care and education advancement for children with cancer in the French African countries. And then we have Dr. Carl Theodore, who is a Caribbean-based medical and public health practitioner, and he was employed also with the St. George's University for about 10 years and is now transitioning to move to another country. Dr. Theodore's concentration and interest in health policy provides a valuable voice in advocating for improved palliative care in the Caribbean. So welcome to the panelists, and again, welcome to all of you, and thank you for joining us this morning. So the format for our session, we're going to keep this conversational and allow you an opportunity to engage and to participate as well. We're going to use a question answer format. So I'm going to pose some questions to them. Then you have a chance to pose some questions at the end of the session as well. And they're going to answer. And in so doing, we are going to meet the objectives of the session today. So we begin with Dr. Gabriel today. And we need to begin with the very basic thing, defining palliative care. So we've come to this session, we've heard a lot about palliative care, but let's begin with defining palliative care. Can you speak to that, please?
Thank you, Dr. Jennifer. Good morning, everybody. In order to even begin the conversation of the optimization of universal health coverage for palliative care, we must look at two things. First, the context and characteristics of the regions where the palliative care has to be implemented, as well as the true definition of palliative care. If we use cancer as a surrogate for serious illnesses, what we see in these African and Caribbean countries is what I would describe, and you will see, as a disproportionate, I dare say, overwhelming burden of illness. What the recent IAC demographic-based data projections show is that the annual number of new cases of cancer will be 35 million by 2050. Astoundingly, for lower middle income countries, this represents a 400% increase in the global cancer burden in the next 30 years. Further, 3/4 of cancer-related deaths will occur in these lower middle income countries. Unfortunately, less than 5% of the expenditure, global expenditure on cancer, will be done in these countries. Would you believe that the situation in the Caribbean is even more bleak? What we do in the absence of national comprehensive cancer control programs, what we observe is that 75% of patients present in advanced stages. 75%. We also have a situation of poor screening, minimal early diagnosis, if any at all, and certainly a dearth of specialist healthcare practitioners. So, could we change the slide, please? Palliative care. To truly define palliative care is to formulate an all-encompassing definition that entails and embodies, what the scope of palliative care is. And obviously, there are, from inception, there have been many controversies and misconceptions and misrepresentations of palliative care that has led to the lack of policies, the absence of training curricula, and ultimately poor implementation and the practice of palliative care. This has deepened the disparities of healthcare access and outcomes. In fact, even among us, the most seasoned practitioners, there are still some gray areas. We find confusion trying to differentiate palliative care from hospice or elderly care. Sometimes we have difficulties convincing our colleagues that palliative care must be part and parcel of primary oncology treatment. And in some cases, in several culturally sensitive areas, it is hard to dispel the notion that palliative care is a foreboder of death. So what we know, and I want us to look at each of these words specifically, palliative care is a medical specialization. It is the comprehensive prevention and relief of suffering. And it targets and aims at improving the quality of life of patients and their families who are facing serious life-threatening illnesses through the early identification and impeccable assessment of pain and other physical, psychosocial, and spiritual problems. The WHO says that annually close to 60 million people will require palliative care, and close to half of those 60 million people will require that in the final years of life. Okay, so next slide. To understand palliative care, we must look at the scope of palliative care, and we must answer the what, where, and why of it. Most of our patients who need palliative care are persons with cardiovascular illnesses, mainly respiratory illnesses, diabetes, AIDS, multi-drug resistant tuberculosis. But we also have kidney failure, chronic liver disease, dementia, Parkinson's, neurological illnesses. So these are the people who tend to have palliative care. Dr. Green?
So, Dr. Green, following Dr. Gabriel's presentation, just so that the audience understands what where we're headed, can you speak to now the wellness trajectory of patients that indicate the need for palliative care?
Yes, Lyndon, one of the beauties of palliative care is that it represents so beautifully, so illustriously, the WHO's definition of health. And it introduces this composite of the psychospiritual, the social, and the physical challenges that are affecting our pediatric and our adult populations facing life-limiting illnesses, and how those changes change with weeks, months, and years. And so these well-being trajectories actually elucidate opportunities for us to intervene preemptively and early, as Dr. Owen just said. And we are able to intervene to reduce the distresses in patients who have illnesses like cancer that present with rapid functional decline. We're able to intervene in populations of patients who may have frailty or neurocognitive decline and have a more gradual progression of that decline. And we're also able to intervene in patient populations like we're seeing in figure 2 that have an intermittent decline, like what we see in multiple organ disease. So that's the beauty of palliative care and these trajectories.
So we often hear about, in relation to palliative care, the whole issue of rights, human rights. Does that play a role? Ethics or ethical practices in medicine. How does palliative care relate to the Universal Declaration on Human Rights?
Well, palliative care occupies a space in medicine that honors a good life until it ends. So when we have illnesses like cancer and its treatments causing significant psychosocial morbidity, 2 to 3 times that of the general population, and these morbidities are so persistent in affecting the patient, their families, and even the healthcare providers that give these treatments. You can just imagine that persons like myself are all too excited and happy when we have advances in macro level, micro level, and molecular level, um, you can turn to the next slide. When we have advances in other spaces that establish the primacy of social justice in palliative care. And let's just start by looking at the macro level index of the gross domestic. That's supposed to be domestic product. Now, GDP is a country's measure of socioeconomic wellness or prosperity. But inherent to GDP is a concept that weaponizes wealth. So one is led to believe that a higher financially resourced country is the only way to prosperity. And so we're shifting away from GDP to a construct that is more inclusive. And this is the Human Development Index. So the Human Development Index is a measure of a country's collective human potential to advance its own standard of living, its education, and its health. And so when we have concepts like Human Development Index, it colors, as we're seeing in that diagram up there, so beautifully colored, we see that these concepts contribute or show how social drivers of health, so the social determinants of health, actually attribute to cancer causation. We have evidence showing that up to 55% of attributable risk is as a result of the social determinants of health. We have other discoveries like the human social genome and psychoneuroimmunology. Substantive work in these fields and their new fields have reoriented the scope of the psychosocial health. And psychosocial health is not, it's often conflated. But I want to impress upon the audience today that there is psychological health that has a separate conference from social health. And so the work of the human social genome has shown that there are changes in our genes that are occurring, genetic expression. So there are changes in our genetic expressions as a result of the social environment in which we live in and the physical environment in which we live in, as well as the perception, my own subjective evaluation of adversity as a result of where I live, how I access food, if I can get food, if I can get nutritious foods, if I can get education. And so I was so happy last year, and I hope I'm not waffling, but I'm so happy last year that the World Health Organization on World Cancer Day last February 2023 launched a new priority focus, which they call the high-level determinants of health. And this is because of the overwhelming evidence coming out of the psychosocial space that is informing us that psychosocial support is truly, it's a misnomer. It's not support, it's care. It exists on the same biological or physiological and pharmaceutical space of offering an impact, especially in low resource countries like the Caribbean.
Okay. So I see you're really, you're very much taken up in the subject, talking about the human rights. And I think you've touched on also the Sustainable Development Goals, goal number 3, the relationship between palliative care and that goal, which speaks to health for all. I'm wondering if any one of the other panelists would like just half a minute to expand on that subject as well. how does palliative care relate to health for all? Especially, the topic is usually broached in the context of death and dying. Does it in any way relate to the Sustainable Development Goal number 3 in particular that speaks to health for all? Would any of you want to comment on that?
Yeah, thank you. So, no, thank you so much for that. The thing about the palliative care is that it focuses on what will eventually be the quality of life. And that quality of life is what allows our patients, all of us in society, to engage in what we would like to do, what we see ourselves, how we self-actualize. And so anyone who's dealing with a severe chronic illness and has this and is not really receiving adequate palliative care in the expanded definitions that we have here today, it means that there is a pressure against that quality of life. And so having this expanded definition, having this supportive care, the psychosocial supportive care, all the way up until end of life care, what that does, it makes sure that the human being, right, is always being taken care of by us, because it is for us that we are doing this. It is for our society that we are taking care of each other in our vulnerable state in health.
Okay, thank you. And I'm sure you would want to hear at this point some of the stories in terms of how palliative care services were being provided. First, we'd look at how it was provided for children in the French African countries. So Kristen is going to share a little bit about a program that they have implemented in those countries in Africa, specifically for children. And later on, we'll look at lessons learned and how that can be incorporated, those lessons, to help advocate and to ensure in an affirmative way the implementation of those programs as part of universal health coverage. So, Kristen, let's hear what happened in the African countries with that program.
Okay, thank you. Thank you, Lyndon. Merci. Bonjour, everybody. I speak on behalf of the GFAOPA, within which I have had the chance, the opportunity to coordinate a committee dedicated to palliative care for several years. Since the 2000s, the GFAOP has fostered and supported the development of pediatric oncology units throughout French-speaking Africa. But in spite of documented improvements in survival curves for selected pathologies, cure rates remain low, and palliative care, even if it is in their end-of-life restricted definition, is a realistic option for many children. To tackle this situation, and because we think that palliative skills should be primary oncology skills worldwide, GFAOP developed a palliative care training program for healthcare professionals working in pediatric oncology units. It is not classical to approach the problem of universal health coverage through pediatric oncology, and therefore the large hospital centers where it usually takes place. Rather, current move aim at achieving primary care-led UHC, including integrated management of non-communicable diseases. But we can argue that palliative care for all is only achievable if all healthcare professionals who care for people with life-limiting illnesses deliver it. This holds true in all health systems, regardless of a country's income status. Moreover, all palliative medicine has taught us the value of taking side steps, and I thank Lyndon Thursford via Karim Hassani, a colleague from Kinshasa, who was not able to attend this meeting, for giving me a place in this forum, even if it's not very comfortable. To come back to the training program, each unit could send 3 trainees, providing they had come up with a project to improve their existing palliative care and or pain management practices. Trainees had to present their project and work on it during the sessions and commit themselves to implementing the final version. 3 training initial sessions held in Dakar, Abidjan, and Rabat were attended by 65 multidisciplinary trainees representing 19 pediatric oncology units in 15 different African countries. An interim assessment in the following year showed that 9 teams had begun to implement their project and were considered ready for a deepening session in Marseille, while 7 teams who didn't would benefit more from site visit support. These somewhat disappointing results raised questions for us, and we tried to identify the obstacles to the implementation of the projects. We will later expand on the lessons we learned from the entire program and how we are trying to continue it.
Great. Thank you, Christine. So obviously, training was a key component in ensuring that at least some of the teams could deliver or commence the delivery of the service for children in Africa. Let's go over to the Caribbean now and let's see what's happening there. Do we have the same challenges? So Dr. Gabriel, can you speak to some of the challenges and barriers in terms of policy and practice that impede palliative care programs implementation in Caribbean countries?
Satisfied. So the first aspect we must look at is the diverse socioeconomic, cultural, and even healthcare landscapes that exist in the Caribbean region. I'm sure most people here, when you speak of the Caribbean, you speak of Jamaica or Barbados, for Rihanna, I suppose. But so just so that you see the large disparities, Jamaica has 3 million people. St. Lucia, 180,000. Jamaica has a university campus with a university hospital like Trinidad and Barbados. So obviously the tradition of healthcare is different to a country like St. Lucia. Trinidad has a population of mixed Indian, Chinese, African heritage, and so on. The rest of us may be more, African heritage. So there are specific socioeconomic characteristics of these countries that augur against having a uniform, one glove fits all type of approach. And obviously, the resources in each of these countries would be different. The availability, limited resources and infrastructure, as for instance in St. Lucia, we don't have things like radiotherapy, limited chemotherapy. So that limits how people have access to healthcare and obviously access to palliative care services if they exist in the first place. Certainly the shortage of healthcare personnel. As Dr. Telesford said, I was the only oncologist in St. Lucia for 14 years. And now there are 2 of us still servicing 180,000 population, which is still inadequate. We don't have any trained palliative care personnel. Nurses, social workers, and so on. Economic constraints is a major issue. Our government struggle to see about our population's basic needs. So there's little attention to healthcare, for instance. Obviously, the cultural factors. As I said earlier on, it's hard to dispel the myth that palliative care means that it's an automatic death, because in general, people try to apply it to end-of-life situations.
Yeah.
Certainly inadequate education. So there is no national drive from NGOs and other groups to advocate for palliative care. So we lack that education both at the grassroots level as well as our clinicians who do not, have palliative care incorporated into their training modules. So neither medical students, nursing students, or anybody has the palliative care as part of the curriculum. So there's the lack of education, and people do not seek palliative care because it's not considered part of clinical care. So these are interesting hindrances, obstacles to policy intervention and so on, and getting things done. But we do have some opportunities. We can piggyback on already existing healthcare services, oncology, for instance. We need to look at a whole of society approach because there are cancer support groups who would be advocating for the betterment of quality of life of their survivors. We do have opportunities for international collaboration. We'll mention them down the line. We have the ECHO program, which is a program driven from Harvard by Mark Stollenberg, to where every once a month there's a 90-minute meeting online where all these community general practitioners, specialists in the region meet, and we discuss cases sometimes. And there's a didactic presentation of some topics in pain management and communication and elsewhere. We have an opportunity for telemedicine, where specialists from overseas can have direct contact with the doctors seeing about patients. And obviously, if we come together, we can have targeted and recurrent public education campaigns. So there are some opportunities for advancing advocacy for palliative care in a universal health coverage scenario.
Definitely. Thank you so much. So now with an understanding of the challenges and opportunities that exist in the Caribbean countries and the program done in the French African countries, I think the next thing we need to look at now is how do we capture these points, these lessons, these opportunities, and ensure that it is transformed into reality in our system. So now, yesterday at the World Health Assembly session, they spoke about the monitoring tools that are in place, the training programs that they intend to deliver. But let's talk a little bit here. Now, the UN is certainly encouraging governments, because governments have a key role in this as well, encouraging governments to adopt policies in support of universal health coverage, certainly. And as you said earlier, the drive or the thrust is to ensure that palliative care can be incorporated in some way into our primary healthcare system as part of the universal health coverage package. Now, can you expand, Dr. Green, can you expand on the integration of universal health coverage in primary health care services?
Sure, Lyndon. But I think I might need a little help with this one. So, universal health coverage and primary health care hinges on one key principle, and that is social justice. In majority of Caribbean nations, universal health coverage is aspirational, but primary health care differs from universal health care coverage. Sorry, I hope I don't mix up. Maybe I should just stick to the acronyms. So PHC differs from UHC in that it aims to ensure that the population is achieving the highest possible level of health, while UHC is aimed at ensuring that in achieving access to quality of health along the life course, persons aren't impoverished. So it's a shield from financial hardship. And so while we aspire for UHC in the Caribbean, we have the successes of developed and developing countries that have redesigned their health systems for people, with people. and that is opposed to other health systems that are designed around diseases and institutions. So that's what encourages us in the Caribbean, that it can be done with limited resources once we adopt a participatory approach.
Great. And Dr. Gabriel, you might want to build on that to speak to now the framework. Is there an approach, a framework that can be used to now put this into action, incorporating palliative care through universal health coverage into primary health care?
Yes, thank you. Just as a preamble, as a practicing oncologist, one of the first things that we encounter is the concept of financial toxicity, which, you think is something alienated from medicine and so on. So, it is known around the world that the cancer diagnosis is the first cause of bankruptcy of certain families. So certainly in a low resource setting, that is a major issue, and that's where universal healthcare comes into play. Notwithstanding, our governments, and what we have seen happen historically, is that our governments, lacking the resources, what they do is to create a basket of services that we allocate to universal healthcare, which means in our experience, cancer treatment, cancer management is not within the basket of services. So those patients who are diagnosed with cancer cannot benefit from the universal healthcare coverage, the health coverage that we want to have. So it's difficult in low resource setting to access universal health coverage. And what we need to do initially is to create a consensus. And we can do that by establishing a national policy and guideline for healthcare in the first place, and in this case, palliative care. We need to have training and education for our specialists, our healthcare providers, as well as caregivers, social workers. So it has both at the tier of attention, medical attention, and those who advocate for their families and their patients. There needs to be a sustainable, dedicated resource and funding for palliative care. Otherwise, it is not sustainable. We need to nurture a broad-based community participation. We say a whole of society approach, all stakeholders involved. And obviously, what we can do, and sometimes the WHO actually allows us to access opioid medications, via a system, that is accessible for poorer countries and so on. So one of the things that doesn't happen in our setting is that we don't have multidisciplinary team approach. So we need to enforce and enhance and strengthen healthcare provider collaboration. It is hard to establish palliative care units and hospitals, but we do have elderly care homes, which could, if you tweak it adequately, you could transform with government input, NGOs and so on, into hospices. Implementing telehealth services in a structured way. We actually had a situation where corporate society, one of the larger hotels in the region, facilitated the equipment and resources for us to do telehealth medicine. But most importantly, our intervention must be data-driven. So we need to establish a way of data collection so that we can do evidence-based medicine. And obviously, create a strong support system that will allow us to have the pitfalls that we will have along the way in terms of succession planning. So when Owen Gabriel retires, there's somebody else to take over because there are so few of us. So it's important to create a framework for establishing a sustainable palliative care service.
Well said.
Lyndon, may
sure.
I just add that the primary healthcare space is one in which there is access to multiple disciplines.
Yes.
And so palliative care would be ideally housed in such a space. And the beauty of palliative care is that it's a well-oiled coordination of multiple disciplines. And so that's why I concur that primary health care is the ideal space to house palliative care.
Definitely, certainly. But as Dr. Gabriel said earlier, our Caribbean culture, and I'm sure in the African countries as well, because you have tribes and groups and so there, um, you know, the differences between those groups can actually be a enabler or a hindrance to palliative care. People have different attitudes, different perspectives, knowledge levels, approaches to palliative care. Do you want to share very briefly with us how those cultural, socio-political, economic factors can act as a hindrance or enablers of palliative care implementation in the Caribbean region? Just very brief.
Okay. So African nations and Caribbean countries have well established strengths in religion, spirituality, and community. Those are well established. And so the community participatory approaches that have been used in other spaces and are being adopted in the Caribbean provide the gold standard for developing culturally sensitive palliative care solutions. Thank you. So although the wheels of change grind slowly in the Caribbean, we are encouraged as clinicians that the micro plans that are actually on the desk of our chief medical officers in the Caribbean are arrived at through consultation with persons in the field who are championing palliative care. In the Caribbean, religious institutions like churches are a significant contribution, or it's a space where primary healthcare services are accessed free of cost to patients, right? So say around time to go back to school, you have churches across the islands just offering multidisciplinary health services to the masses. So a barrier that I want to say, it's on the surface, it is a barrier. But with a little bit more depth, it is an opportunity to find new ways to increase the low uptake of cervical and prostate cancer screening by using participatory approaches with communities. Now, oftentimes as clinicians, we feel like we have to be prescriptive and apply the science or the evidence. But because we're so diverse in the Caribbean, what we're having is a lot of backlash. Or men are not willing to do the DREs, the digital rectal examination. Or women are not willing to do the pap smears. We're faced with mental health stigmatization because culturally, there are cultural beliefs that if you disclose social dysfunction, so if you share with your doctor what's happening at home, that's unacceptable. If you share what's happening in your head, so if you're having mental health symptoms, that's a sign of weakness. Those are cultural beliefs that if we use a participatory approach, so I'm going to mention quickly two initiatives that are happening in the Caribbean space, and we have a series called Healthcare Professional Wellbeing Initiative that is innovative and rehabilitative in modeling compassionate health systems. And this is upskilling our clinicians to be culturally humble. And in having a cadre of clinicians who are skilled in cultural humility, we can address much better some of these, or incorporate or see these cultural beliefs as no longer being barriers but enablers. And quickly, The second initiative is the creating blue zone solutions for cancer,
Right.
which is a participatory space that has been created between the social, so we're trying to mobilize the social space with the biomedical space to find solutions to fill the gaps in cancer care. So it's all about, for me, participatory approaches to finding culturally sensitive solutions.
Inclusive approaches.
Yes.
Yes, definitely. Thank you. And Christine, we're going to go back to you now because we want to hear about, we've heard about the Caribbean, the challenges, some of the programs being implemented, and how they are addressing and breaking down barriers to providing palliative care. What were the lessons from your program in the African countries?
Thank you. First, we must say that it's difficult to assess the impact of such a training program. One of the outcome measures was, as we've seen, the implementation of projects, and it has encountered real difficulties due partly to the small number of trained and stable caregivers, and that is a political problem. We can add that several key ingredients of palliative care, including interdisciplinary work, patient-centered care, and institutional support, mean that the country's entire healthcare system may have to be operated in a different way, which can take time.
Yeah.
The heterogeneity of achievement is worth being pointed out. The depth of political commitment to healthcare policies was clearly illustrated in Morocco, for example, where a royal decree in 1215 imposed a framework for the provision of palliative care in hospitals, such that 3 of the 4 Moroccan teams who attended the program focused their project on this topic, this palliative care topic. It is noticeable too that, especially in sub-Saharan countries, the units who began to implement their projects were those where a national cancer plan or active palliative care association were available. But we have to underline as well that lack of communication between teams and the fragmentation of services within pediatrics, within hospitals, between hospitals and community, making it so difficult to multidisciplinarity approach, is still to be addressed. And I do think that it's not only a medical problem, it's also a political problem. How it might be extended? No? Further? Well, lack of healthcare professional training, as well as misperceptions of families for children with cancer, have been cited as major barriers to accessing skilled palliative care. Education is therefore a solution. So we intend to go on with our training program, with a training program. But we think that we have to shift from very large-scale training projects to more targeted initiatives in order to adapt as best as possible to the complexity of local systems. We have to redirect training efforts to peripheral centers and community health centers, as has already been done in English-speaking Africa, while maintaining collective mentoring that promotes sharing of experiences and data and mutual trust, which is quite fundamental as well. I would say this program should be palliative inspired. That means anchored in diverse or still unknown realities, organized in a pragmatic way based on identified needs and opening the possibility of mutual awareness of trainers and trainees.
Great. Thank you so much for sharing those, and I'm sure that there can be transfer because you've now captured those lessons and approaches to move forward. So maybe by the time of we have this conference again, you may be able to present a different set of information that the knowledge has been shared, managed, transferred, and then you're making some progress. And now we go over to our final speaker before we wrap up. Time has moved by swiftly. So we just want to talk about now advocacy. This is a critical and very important step in the process of changing our societies, changing people's thinking about palliative care. So Carl is going to speak to how do we go about advocating and what are some of the approaches that can be adopted in our advocacy programs to ensure we can be effective?
Merci, Lyndon. Bonjour. Je ne parle pas français. I speak English. So, as we heard today, one of the things one of the barriers to inculcating or introducing palliative care inside of universal health coverage is that there's a narrow definition of palliative care. Palliative care is, from the French palliatif, which means to alleviate, right? And but it also means from Latin to cover. So it's all covering, to cover, right? And so if we use that definition, it means that we could take end of life care to be on one spectrum of palliative care, and then we can take the socio-psychological care as the other spectrum of it. And so that from the moment someone exists with some type of health care issue, they begin having access to palliative care. And if you define it like that, then for a resource-strapped country, right, the LOMEX, it means that they're more likely then to spend money on that as opposed to trying to spend money on care that is for somebody who's not going to add to society after they're gone. And so that helps now with our advocacy. WHO has given us, and we have a lot of evidence of how beneficial it is to add it into our care, how beneficial having universal coverage is in our systems. And so the first thing then in that advocacy approach is recognition that it's going to take a long time, that it has to be constant, and that it has to be culturally nuanced. It has to, for each country, there are differences. There's some similarities, but there are a lot of differences. A lot of stoicism is kind of constant in our region, but you need to have this advocacy, because it is from that society we get our doctors, we get our politicians, we get our nurses, we get our patients. And so this general understanding about palliative care, that definition needs to be, education needs to go to that. And so that begins with our advocacy. And so with advocacy, then it means there must be some research. We need to understand then who are these, we will call them policy actors, right? So government officials, medical healthcare professionals, etc. These policy actors, we have to identify them. We have to identify from these policy actors what side of the policy they are. What are their beliefs? What are their primary beliefs around the policy? And then what are their secondary beliefs, meaning the implementation, how it is done, how it is rolled out. And so having that understanding, that research allows us to be able to know then what are our objectives, what are our long-term objectives, what are our intermediate objectives, what are our short-term objectives. And that then, through that advocacy planning, we're now able to create these objectives. And these objectives, everyone knows, has to be SMART plus C. So they have to be specific, they have to be measurable, they have to be achievable, and the last C, which I found is just they have to challenge us. So we can't just do a simple objective that everybody wants. And so taking an understanding of what type of resources we have, building up that resources, building up that library of information is important. Using research-based identification of strategies, and then identifying who your targets are. Once you understand who your targets are, and you know who because you've been doing your research, you know what the coalitions look like, who are on one side of the policy, who's on the other side. You then able to determine who's an ally and who's an opponent, and that opponent may not be somebody who's like, I don't want this policy. It could just be that it's somebody who doesn't want to give opioids because they're not feeling comfortable to give opioids, and that becomes an issue. And so we have to identify that as something that we need to do. And with that research and with that understanding of your coalition, we now take that understanding and we start now having targeted approach. We say, okay, this person requires this and that person requires that. And by doing that, we now can apply these strategies. There are a lot of strategies, and a lot of that we've talked about before, centered around education. But in addition to education,
Carl, as you go on,
Yeah.
just to let you know, we just have about 3 or so more minutes
Thank
to
you, no
wrap up.
problem,
Plus, we
yes.
want to take 1 or 2 questions from the audience.
no problem.
Okay.
So you have some strategies, and so this here is just an example then of how we would do it. So we'd have our actor, we would have an understanding of what their policy belief is, their their primary belief, and then what their secondary belief is. And so from that, we now could determine what our strategy is. We create our goal, our SMART goal. We know what our resources are. We determine whether they're an ally or if they're an op. We identify who they are, and we have our change agents. We take this strategy, so education, expansion of our policymakers, etc., and then we say, this is how we're going to do it over the next 6 months, over the next 2 years, over the next 10 years. This is going to do it. And so, as we kind of we adding palliative care as part of the essential package of health services now becomes a little more easier, because now we have a larger coalition of people wanting it to happen. And so I'm asking all of you to become advocates today. Go and take one person, ask them to redefine palliative care. One person, especially somebody who is an oncologist or somebody at the highest level. Because once we change that definition, we begin to have the platform to change what we think about palliative care. Merci.
Beautiful. Thank you so much. Okay. Thank you. So now we just have 2 minutes. So does anyone have yes, seems like we already have a question.
Hello, good day. Sorry, my name is Dr. Tolo. I'm from Antigua and Barbuda, but I trained in Jamaica, so I actually have experience both from a country that has a lot of the specialties needed for persons diagnosed with cancer, but now in a setting where that's even more limited. However, it's so encouraging to see some of the work that's happening in the Eastern Caribbean through like the cancer
Portal.
support, right, the portal. And also just seeing you today and some of the things that you're mentioning. And it's so important that we identify where our specialists are and see how we can bridge the gaps between the different islands. The other thing I want to say is that we also need to address palliative care in our training as doctors, as nurses, because really and truly we are, before they get to you, the specialists, they're seeing us in primary care, they're seeing us, long before, and how they, as patients diagnosed with cancer, perceive palliative care is determined by how they're treated by us long before they get to you. And so the other thing I think we need to consider is that, especially certainly in our setting, palliative care is institutionalized. It's seen as care that happens at the hospital. It's seen as care, it's almost a hopelessness with it. And so maybe part of our approach might be taking it from the institution and seeing palliative care as something that happens in the community and something that more persons are part of, more stakeholders, so community members, family members, you know, and nurses and doctors that work in the community as part of that palliative care, not just residing with the oncologists, not just residing with the nursing oncologists, which, I mean, are limited, and you can't do everything, right? So I think that's something we need to think about. And just lastly, based on some of the things that you've said in terms of the determinants of health and their connection to cancer. So, and a lot of the points that have been made throughout the Congress is that cancer, it really is a culmination of not just biological factors, but socio-economic factors. And when we take all of those things into consideration and we start talking about quality of death, before we start talking about quality of death and how societies perceive that, we have to talk about how societies perceive quality of life. And how we treat quality of death starts long before the onset of illness, starts long before persons are being faced with death. How does society, how do individuals perceive quality of life? And so I think long before we start talking about interventions that deal with palliative care, we have to talk about interventions that deal with how society and countries deal with quality of life and changing those perceptions.
Thank you. Thank you so much. Well said. I see we have about 3 more hands, so we can keep it brief. I think this gentleman then. Yes.
Okay, I'm Rolf Hansen from Namibia.
Hi.
I have the wonderful pleasure of working with Groote Hospital, UCT, University of Cape Town in South Africa, Western Cape. I've got a brilliant palliative program. What does sadden me is in the 2 sessions on palliative care at the UICC Congress, this is the whole. So we still need a lot to do within the World Cancer Congress even. And that is something I want you to take back to the UICC board and say, this is something we need to address because it's all about advocacy and hope and we're going to save lives. It's not the reality. Palliative care is an interdisciplinary approach from the moment of a terminal diagnosis, a life-changing diagnosis. And recently we started, so I'm the head of the Cancer Association of Namibia and also Palliative Care Namibia. And I had the pleasure of starting Palliative Care Namibia. And when I started with the recruitment process, I had thousands of applications of nurses. And then when we start talking about palliative care, in the middle of the interview, they stop and they walk out. Because doctors, we are all trained and we have this mindset that we're here to save lives. No one of us can save a life. It's quality of care. And that means that palliative care should be integrated into nursing school curriculums. Doctors should have this conversation. Because at the end of the day, from roughly about 350 applications for our palliative care program, that is a market-related salary that we can offer. I had about 5 doctors and a small team of about 10 nurses who were truly passionate about palliative care. The rest are taking it for the job. And that's not what I want for my team.
Exactly.
So it's a statement, but also effort that we must all put in. Because this is a small team, but it can be a passionate team that transcends to everyone down there who's all survivorship and advocacy. It's all important. But this is the golden thread that runs through everything that we do. So, yeah, just a thought in there.
Thank you so much. Thank you. Appreciate that. And good luck as you continue your program as well.
I'm Kathy Pritchard-Jones, paediatric oncologist from the United Kingdom, and I'm here representing the International Society of Paediatric Oncology. It's a sort of question. I think this is the best session I've been to in the whole Congress, and I absolutely agree. Well, the next one might be the GFAOP session, but I agree that, you know, where we have been placed reflects badly on how we're looked at in the greater part of the Cancer Congress, and I would support your advocacy to have a plenary session in a bigger hall. But the comments I wanted to make, is fantastic to hear from all you speakers. And I would say the issue of palliative care and wellness that you're talking about is a problem in all countries in the world. I mean, even though the UK has got palliative care services, highly variable for the whole population. But I think what you have given examples of is really good learning, what you might call south to north, for how the UK addresses the disparities in accessing this sort of supportive care and working in a participatory way with communities of the sort of very ethnically diverse populations we have, certainly in our big cities in the UK. Because I know that end-of-life care, and I speak from the perspective of a childhood oncologist, can be very challenging, and there's huge sort of church support in the community, but there's this vision that if your child deteriorates at home, even though all the home support's been put in from the oncology centre, when the child has the final acute deterioration, parents often rush to the emergency room from certain community backgrounds. And I think that is about a cultural, educational thing, that actually the child is better off staying in the family home with the support, and it can be brought in an outreach way. I've often seen children being inappropriately resuscitated in hospitals because the parents wouldn't admit that the child was in the terminal stages of life, and maybe they'd gone to a different hospital to the one that was treating their cancer, and this can be an issue. So I think there's a lot of learning, and I'd like to know, is this session being recorded as a totality, and can it be released in the public domain outside the Congress website? I think people would find it very interesting. Thank you.
Thank you. We certainly appreciate that. Thank you so much. Okay, so our panelists are going to remain around for a few minutes because I think another session should be here. They're going to be around, so please feel free to engage with them. Thank you so much for being here. We appreciate you.